Good afternoon, everybody. I am from microbiology unit of the university, and part of what we do is providing public health services to the community. We have hospitals around, not too far away from the university, and we work in collaboration with the doctors. So they look at problems around, discuss with the university, the department, and we set into motion to look at what is happening. One of the studies I'm presenting today is the prevalence of hepatitis B and C viruses among HIV-infected children in northern Nigeria. One of the presenters this morning that spoke about adherence did mention that coffin makers have actually gone out of business. But I don't think they have completely gone out of business because we still have viruses like HBV and HCV lurking around. And infecting HIV children actually is a big problem. And Nigeria is one of the countries with the highest prevalence of HIV in pediatric patients. So you can see that we have this problem on our hands. And HIV is also known to increase the pathological effect of the HBV and HCV, and also potentiates reactivation of latent infection as a result of the reduced immunity. The preponderance of co-infection with these two viruses in sub-Saharan Africa is actually threatening the gains of ART. And careful studies of these interactions are important for informed approach to providing clinical care, public health initiatives, and guiding future research. In view of this, the main aim of this study was to determine the prevalence of HBV and HCV in HIV-infected children and determine probable risk factors. The study was actually a cross-sectional study where we had to get consent from parents or guardians of these children. It was actually an informed decision because generally you give them a health talk and then ask if they are ready to go in for the test. We had questionnaires for them, which we filled to give us the socio-demographic information about each child. We had about 200 HIV-infected children who were ready, who consented to the study. And generally, we take blood by venipuncture, harvest the serum, and then screen for the two viruses using the rapid test based on the manufacturer's instructions. The result was generally, there was a prevalence of 14% of both HPV and HCV prevalence. HBV was prevalent in 3%, while HCV was prevalent in about 11%. We didn't really look at vertical transmission because we're just capturing the patients that were reporting to the HIV clinic. They are usually referred to as special clinics. So we're just looking at that. So there was no issue of maybe looking at vertical transmission. Now, initially, we were not looking at HCV. The concentration was on HBV. But now there's renewed interest in HCV because we have realized that, there are so many people coming down with HCV now, which was actually neglected. And then maybe because of the availability of HBV vaccine and non-availability of HCV vaccine. Maybe that was why we're not actually looking at it, but now it's a huge problem that we're looking at. And the relatively low prevalence of HBV. We are not actually excited about the results, or maybe we think this is the real thing. Because even when we looked at vaccine uptake, we discovered in another research, sorry, I'm not presenting it here, but in another study, we discovered that the HBV vaccine uptake was not too good, because you discover that most mothers did not complete the dosage. And we have another research that looked at the seroconversion using a particular HBV vaccine that was brought into the country. And it was not very good. The seroconversion after a single dose was not too good. And another thing with the prevalence of HBV is the presence of occult HBV, which really we don't have facilities for that, because you find that some children are hepatitis B surface antigen negative, but then they are actually HBV DNA positive. So it's very possible that we still had some of these cases. But then the HCV was relatively high. And some authors, like Daurung et al., had actually noted that the ability to induce seroconversion of the other depends actually on the chronology of infection with any of the two viruses. Other results from other studies, though not in children, have actually reported HBV of 7.7% or 6.6% and HCV of 5.2%. One of the studies did not report anything. Sorry, there's a mistake there. There was no HBV, HCV co-infection. In fact, our study did not report that either. Now, looking at the seroprevalence based on what we looked at as risk factors, you could see that based on sex, there were more females with HCV than males, and more females with HBV than males. But all these did not have any significant association. But like we always say, the idea of basing arguments or basing decisions on statistical significance is not actually sacrosanct when you are dealing with medical issues, because some arithmetical differences will make a lot of sense if you're looking at the decisions that you need to take. Also, in relation to age, we discovered that it was not actually a risk factor either. And blood transfusion really was not a risk factor either, even though we had, a few people that said they had had a blood transfusion and they still had the viral infection, but there were those that had not had any blood transfusion but had very high HCV infection. As for the HBV, there were more people with HBV infection that had had a history of blood transfusion, more than those that had not. All the same, it was not statistically significant, even though there was an arithmetic significance. The part of the country where this study was done is an area where we do a lot of scarifications for one reason or the other. So we equally looked at children with scarification marks, and we discovered that most of the children with scarification mark actually, there were more children with HCV that had scarification marks than those with HBV. But then it was still not statistically significant. Now, for those that had a history of HBV vaccine, we had so many of them that had HBV infection. And like I earlier said, sometimes you discover that the potency of the vaccine is not, you don't get the full benefits, because sometimes we find mothers don't usually take the full doses of these vaccines. So that could be one of the problems that we had. Well, in conclusion, the study has shown the burden of co-infection with the two viruses, HBV and HCV, as 3.0% and 11% respectively. There was no identifiable risk factor for the two viruses statistically, not arithmetically, because like I pointed out, we had arithmetic differences, though not statistically significant. Well, not identifying risk factors statistically has drawn the attention to the probability of some obscured factors or locally specific risk factors. Now, what we're recommending is, one, routine screening for the two viruses in HIV-infected children, and the establishment of treatment protocol for co-infected patients to reduce hepatotoxicity. And then we need to find a way, another way, other than what we're doing right now, to strengthen hepatitis B immunization program. Future work, we intend to look at larger studies and then do it longitudinally. And we also intend to include more probable risk factors vis-a-vis the socio-cultural practices of the study area. And another thing that we intend to look at is the molecular epidemiology, because in doing that, we are likely to be able to capture the occult HBV, and also, sorry, I did not mention that, looking at the different genotypes of the HCV, because treatment, actually the length of treatment depends on the genotype. So we'll need to know the genotype of the HCV circulating in that area. We wish to acknowledge with thanks parents and guardians of participants, the management of Dalhatu Arab Specialist Hospital, Lafia, and Dr. Nyabam, who was the statistician. In conclusion, it is pertinent to investigate hepatitis chronicity, especially in regions endemic for HIV, HBV, and HCV, like where I come from. Thank you.